Hello, everyone, and welcome to today's session, Brain Health Essentials, Strategies for Adapting Clinical Practice and Workflows to Optimize Cognitive Function in an Aging Population. Just want to introduce myself and say welcome. I'm one of today's panelists, Anna Chodos, and I'm also joined today from someone who you'll hear a lot more from later, Dr. Chodos Gaster. We want to say thank you to PeerView, who put together this program. They were able to do so with an educational grant for this symposium provided by Lilly. And please, as we're going along, respond to the polls on your screen and enter questions in the chat window so we can respond to them. Also, at the end, please note you can visit this website to get the slides, the practice aids that are included, download them, and I believe also do a post-test. So now on to the content of the talk. Our goals for today are to improve your understanding of Alzheimer's disease as a continuum with pathological changes that starts years before symptoms appear, and to identify opportunities for prevention and early detection. We want to equip you with strategies to identify and manage the modifiable risk factors that can preserve cognitive function. We want to provide you with tools to educate patients and families about brain health and to initiate conversations about cognitive concerns, and to improve your ability to integrate cognitive testing into your practice to improve early detection of cognitive changes. So I'm going to go over some of the background of dementia, its prevalence, what we know is going on with folks pathologically, and that'll help really set the stage for what we understand about brain health and how we can make that really real and meaningful for our patients. So really briefly, dementia prevalence is something which we review a lot, and I just want to bring your attention to some of the numbers here. The risk of developing dementia at any point in your life after age 55 in the United States, in studies done in the US, is about 42%. And we're looking at what appears to be increasing risk over a lifetime as our data and studies get updated. We estimate about 500,000 cases this year, increasing to 1 million cases a year by 2060. So we know we're facing increasing prevalence of dementia. We also know that there are differences among populations and groups. So rates of developing dementia are higher in women, people identify as Black or Hispanic, and people have certain genetic risk factors like the ApoE4 allele, which many of you may already know about. And what further complicates our clinical management and addressing these disparities is the fact that among populations that are from racial and ethnic minority backgrounds, they're less likely to be diagnosed at a mild stage of disease. So we have so much opportunity to do better and address brain health as we're going to address today. So we're going to go over a little bit of orienting ourselves to what's going on in people's brains and the unique opportunities for intervention and brain health intervention in particular. So there's a lot going on this slide here, but what I want to draw your attention to is there's various definitions of Alzheimer's disease in particular as one of the many causes of dementia. And as you can see from going from left to right in the green and blue boxes, people are progressing through the clinical and pathological stages of dementia. And in the blue sort of solid arrows at the bottom, you see an overlap of what's going on. So the pathology, the neuropathology begins before things like behavioral and psychological changes may start occurring, which begins slightly before what more global cognitive impairment may be evident. And then functionally, it's the functional impairment that we see in the later clinical stages of the disease. Another way to look at this on this graph is that what we know is sort of all the shaded boxes earlier on indicate the changes that are going on before the clinical picture of dementia is really apparent. So you see this person's functional trajectory sort of really decreasing when that dementia arrow comes in. But before that, for years, for often over 20 years, Alzheimer's disease pathology is occurring in the brain. And of course, that's a very active area of study and detection. But That is to say that there's a lot that we could be doing, certainly the earlier and earlier we detect this condition. So hopefully one possible future will be that we can detect these pathological changes before even MCI or mild cognitive impairment is present and address brain health and have additional time for intervention in those patients. So now let's get to a concept which may be a little less familiar than dementia or mild cognitive impairment, which is this idea of brain health. And we have a couple definitions presented here just for thought, but really what they're doing is bringing together all these different factors that really count as brain health and brain health interventions. So brain health is not just not having dementia, it's having a state of functioning across cognitive, sensory, social, emotional, behavioral, and motor domains or abilities, allowing that person to realize their full life potential. So we can think of various key determinants and key areas where we're going to intervene. And that would be physical health, environment, physical safety, financial security, and opportunities for social convergence and access to health and social services. So really now we're starting to talk about more of a whole person approach, but one that specifically benefits the brain. So before we move on, please take a moment to answer a follow-up poll about the developmental course of pathological brain changes and cognitive impairment symptoms. And think back to those 2 slides with some graphics on it that I showed you just a minute ago. Okay, so the other concept in brain health that we can really bring to bear here is that there are 14 known modifiable risk factors that account for about 45% of the dementia that we see worldwide. And this really comes out of the work that's done by the Lancet every few years to update our understanding of what we know about modifiable risk factors. So I think another way to think about brain health is if we were to, based on public health interventions or direct individual interventions, address these, we would see 45% less clinically diagnosed dementia. So it's a long list, but I think we can appreciate that some of these things as clinicians really are in our domain. Others, like I said, may be more public health or environmental issues, but things like air pollution, personal alcohol intake, cholesterol, depression, diabetes, educational attainment, exercise, head injury, hearing, hypertension, obesity, smoking, social engagement, and vision loss are all known modifiable risk factors. We know that by addressing these, we reduce some of the mediators to essentially brain injury and damage that are leading to dementia. And so by addressing them, we can prevent and delay dementia. Again, want to point out that many of you are probably thinking this is very similar to cardiovascular health, and that is very true. And how fortunate for us, because we're already really in the mode of addressing cardiovascular health and improving that with patients, and we can do the same here to benefit the brain. Some of the data is in the next couple slides, really giving us this foundation of understanding that these modifiable risk factors are leading to dementia. So one really influential trial has been the SPRINT MIND trial, which showed that intensive blood pressure control can affect dementia risk and reduce it. The other is the CARDIA study, showing that higher cardiorespiratory fitness was associated with lower dementia risk. And again, this is a lot to go over, and we have a lot of clinical tools to get to. So we really wanted to for you to have these as reference, but I'm just highlighting the major points here today. And then a really wonderful trial that's a little bit more recent as well showed that if we take folks who are at slightly higher risk of dementia and really address on a personalized level their risks for Alzheimer's disease and dementia, we can effectively improve what appears to be their trajectory towards dementia. So what they did in this trial is they gave people an intervention that really addressed their personalized risk. And as they went along in their work with their interventional coach to address their factors, they were actually able to update their plans according to the risk factors that perhaps they were addressing successfully. So let's address another, or perhaps this one isn't working out, like increasing exercise. So let's try another risk factor. So we're really getting into the territory of highly personalized risk intervention for folks, and we're really making progress in that area, which I think is incredibly, fortunately, promising for what we're talking about today, which is our ability to affect brain health. So now we're going to go to the second part, and we're going to really start to talk about how we can engage patients and families in brain health conversations. So I want to acknowledge that this work in brain health and being really proactive with our patients around addressing their brain health needs and identifying and addressing modifiable risk factors can be challenging because it's relatively new. And when we survey primary care providers, they express, very understandably, a lot of barriers to prompt diagnosis of mild cognitive impairment or Alzheimer's disease. And really, this extends to a more global approach to addressing brain health and incorporating that into our practice. So 40% or more of surveyed PCPs identified some of these barriers. And I just want to mention a few as it may really resonate with you and your practice. But patients, and maybe sometimes us as clinicians as well, believe that some of these symptoms are normal parts of aging. Patients deliberately don't disclose symptoms or they're not bringing them up. They're reluctant to undergo further testing and assessment. And there's stigma attached to these diagnoses if we start talking about brain health or possible decline. There are clinical barriers such as lack of access to certain assessments or understanding what symptoms are normal and what aren't. So do these symptoms, especially when mild, appear as part of normal aging? And there are limited treatment options, or people feel that there's a limited value of reaching a diagnosis because there's not necessarily a clear treatment plan that everyone feels they can access easily. And finally, things like seeing specialists or getting additional input, wait lists for such specialists to help us out with diagnosis may be too long. And then there's insufficient time in a standard visit. This is a really, really major one we hear all the time to assess patients. But how can we begin to address these issues with patients, knowing some of those barriers and knowing that these are all things that you've probably experienced or really, again, sound very familiar when you think about your own practice? Well, we can use principles of shared decision making to start to bring brain health into the conversation and talk about reducing risk factors. And one element of this, of course, is sharing information. So we can reach better decisions if we know that patients are informed about the fact that we can do something about these risk factors, and if we have access to tools to support them. We want to make sure that they're making an informed choice. So what are their preferences around brain health? How do they want to age and age with their brain? So can we agree on best next steps in that area? And then just having open conversations, engaging in open dialogue, exploring how we can together address these challenges and create time and space in the care plan to address brain health. So just want to, again, plug that you can access some of those resources and decision-making support guides after this activity. So before we move on, please take a moment to answer a follow-up poll about modifiable risk factors that can impact brain health. And now we're going to go over our first video clip of an example of a physician initiating a discussion about the importance of brain health, reviewing modifiable risk factors, and setting up an action plan. Good morning, Ms. Thompson. It's wonderful to see you, even though we're on video today, but it's great to see you today.
Hi, good morning.
So how are you doing?
I've been doing well. I've been doing okay, I should say. Um, for the past couple of months, I've been dealing with a lot of stress at work.
Yeah.
It's just a really busy season for us, and we've been trying to manage it as best as we can, but it really has caused quite a few sleepless nights. And so that's been something I'm really struggling with. It's very disruptive.
I'm sorry to hear that, and certainly something that a lot of people go through. Can you give me a little bit more sense of how it affects your sleep and the sleep that you do get?
Certainly. So I'm typically waking up around 3 o'clock in the morning. I'm up for about 2 hours. I can't seem to fall back asleep. So I'll watch TV or try to make tea, anything to kind of help me fall back asleep. And then I'll go back to sleep and I'll have to wake up about an hour later to get started for the day.
Got it. How's the rest of your routine? Are there ways that you sort of get back on track and get the sleep back on track?
I've been trying a couple of different things. Meditation, walking has been a big part of it, trying to get physical activity over the course of the day. So I have two dogs. I like to take my dogs for walks. We usually spend about 30 minutes outside. If the weather permits, they love it. And it also, for me, it feels like it helps me to sleep a little bit better so that it's not as disconnected as it has been over the past few weeks. And even with that, more recently, it's still been a bit of a challenge.
Okay, and then anything else going on?
I'm just a little worried. So, my mother was recently diagnosed with Alzheimer's. And
Oh,
yeah, it's been really challenging. We've been um, trying our best to manage it, our family, just trying to deal with the fact that she has this diagnosis, but also watching her changes. And I worry about what does that mean for me, down the line. I know that it increases my risk. Um, and so I just worry, are there things that I could be doing now to kind of help, so that perhaps this isn't my path? And I don't know. I've been looking online, and I just wanted to kind of check with you to hear directly from you as to what would be best for me to do.
okay. Thank you for sharing that. I'm really sorry to hear about your mom's diagnosis. Could you just remind me how old she is?
My mother's 75.
75. Okay. Thank you so much. Um, okay, yeah. Why don't we and I'm making notes and we will get all this at the end. I do want to also just go over your test results. Um, I don't know if you can see them here, but one thing I just wanted to point out is, well, one is your some of the blood pressure readings we had previously. So a bunch of things, as we get older, sometimes if we're a little less active and more stress, certainly disrupted sleep, all these things can contribute to a little bit higher blood pressure. But it looks like we've had a couple readings where it's starting to get into a higher range for you. It previously wasn't that high, and it's technically what we might call pre-hypertension. So um, we want to. I just wanted to point that out because I want to talk about that in the big picture for you. And then the other is just some of the like cholesterol, or sometimes we call it lipids. Those blood tests also showed a little borderline high on the cholesterol front. So I just wanted to talk to you about that. And then I think putting it all together for you, and especially with your mom and this new diagnosis, um, I think if it's okay, I'd like to talk a little bit about sort of the brain health aspect of your care.
Absolutely. That would be great. Thank you.
Great, absolutely. So, the really at this point, we know that a lot of things that support the heart support the brain. There's really a very, very strong connection to all the kind of things we've learned about over the years that are labeled heart health. So, high blood pressure, high cholesterol, sometimes if we have overweight or obesity, those things have a tremendous impact on the brain as well. So, we can kind of think of them together. But the really nice thing here is there's a unifying thing we can focus on, which is exercise. So, exercise can help with the mental health, the anxiety, the stress, as well as the sleep. It really helps us get tired, basically, and get on a schedule that can help us get higher quality sleep. And turns out exercise is one of the most powerful, potent things we can do for our brain. So I'm going to take a step back and just review really quick that for your brain health plan, I think for you specifically, tailored to you, we want to focus on these cardiovascular risk factors like more exercise. We might want to treat the cholesterol sooner rather than later for you if you're not able to get it down with more exercise and more better diet. So I'll give you some information. I'll include it in the summary about heart healthy and brain healthy diet, and then working on the sleep. All of those to me seem really one. You'll probably feel better and notice a change, and then we can also follow up on that relatively quickly and make sure we're making progress. And then with your mom, definitely it can be true that if family members have it, that it increases your risk. And so I think we'd want to next visit, we might want to spend more time going through your full family history, see if anybody else had it. And sometimes we can even refer you for genetic testing to see if there is some increased genetic risk.
Okay, that would be great.
I think the other thing is, I'll want to make sure today that I put in your plan just more information about brain health and its connection to Alzheimer's disease and dementia in general.
That sounds great.
Would it be okay to follow up in 6 months and just go over this again?
Yeah, that's perfect. Absolutely.
And wonderful, and then we'll recheck your labs, with the main goal, it sounds like, of you increasing exercise. We'll see how that affects your sleep, and sounds like your stress level may naturally come down if work gets a little easier, and if it doesn't, we'll definitely check in about that. So thank you so much, Ms. Thompson. It was really wonderful to see you today.
You're so welcome. Thank you. It's nice to see you again, and I'll see you in 6 months.
I hope you were all able to get something out of that video. And now I'm going to bring in my co-presenter, Dr. Barak Gaster. Welcome to the session. And we have the opportunity to discuss the video, which obviously I had already seen at least once or participated in. But how did the series of tailoring of the recommendations and then trying to tailor it to the patient seem to you in that instance in terms of brain health effectiveness?
Yeah, so first, just want to say, like, you're such a great doctor, Dr. Chodos. Like that was awesome, and this really does speak to exactly the kind of thing that we all face in primary care every day, which is how to talk to people about cholesterol and blood pressure. And I think we have just come so far. In the 20 years I've been practicing primary care, we have come so far in really embracing this concept of heart health, and that it is a relatively easy thing to do, to really just sort of expand that to say every time we're talking about heart health, we really also should be talking about brain health. And that we have all faced that difficult situation of how do you get somebody to start a blood pressure medicine? How do you increase their blood pressure dosing to get them to a target range? And being able to talk about brain health as part of that process really is an incredibly powerful way to engage people and get them sort of excited to go on that journey with you.
Yeah, as you were talking, that makes a lot of it's all of a sudden the parallel is even more obvious to me that we've just had a lot more time being comfortable bringing this up and making it part of our routine counseling and care planning with patients. One thing that occurred to me, like a missed opportunity, was to maybe keep that parallel a little more obvious for during the conversation with the patient. Like we really we now know, just like we spend years trying to keep our heart healthy to prevent a heart attack at some point way down the line, it's sort of the same thing with the brain. We're trying to influence the health of the brain at this stage. Obviously she was a young person, so that we know that as you get older, you'll have much less risk of the dementia that you're concerned about. And I am too. So that was one strategy I was thinking maybe I could have employed a little better.
And as much as people care about their hearts, I think it's very easy to talk to people about their risk of having a heart attack, but there is almost nothing that people are more afraid of. People are afraid of cancer for sure, but people are extremely, extremely anxious about the future of their brains. And more and more people are having experience caring for people with Alzheimer's disease. And so when you can like make that link, getting that connection, and it can be such a struggle to get people's blood pressure down to goal. This talking about brain health, talking about the risk of Alzheimer's disease is just so powerful and important.
Yeah, and in her case, she has this example of her family member and where you don't want to diminish that person in any way or their life, to say, well, we know that we could potentially delay something like that for you or even prevent it entirely if we're really more aggressive now. And that might, I think you're right that brain health is, it's almost so important. It's scary. It's that thing that kind of makes people not want to talk about these issues in clinic. Well, thanks for the discussion, and I'm going to hand it over to you.
And great, now it's up to me to talk about patient-centered strategies for managing modifiable dementia risk factors and implementing routine cognitive screening. And so I want to start out by talking about just what the value is of making a diagnosis, that really thinking about making a diagnosis, especially of early stage cognitive impairment, is really such a way to get to better care. And I think the if I was going to highlight the one thing that makes the biggest difference is how much communication with patients and families gets better when there is this diagnosis, in terms of getting families involved sooner, getting better support for them, getting you better support by having connection to a family member who is going to be so much more on top of setting a plan than the person who has cognitive impairment. It is so common for people with cognitive impairment to who are undiagnosed to be coming to their office visits with you by themselves. And maybe you aren't even aware, and they are certainly not mindful of the fact that they're not going to remember half of what you tell them. And so really you can get such better care by making this diagnosis and bringing family members in sooner. That really does make care makes providing that care easier and less chaotic. When patients are drifting in and out of our clinics with undiagnosed cognitive impairment, that's what leads to the crazy chaos of people missing appointments, not following through on plans. And and as we've been talking, these are really steps that we can take now to improve people's cognition. And this is so much about like what we as primary care doctors do best. I mean, it's really so about patient-centered care. We provide continuity of care for so many chronic diseases, and management of cognitive impairment really is in that same ballpark as a managed chronic disease. Really is and should be a primary care disease in the same ballpark really as diabetes. And so let's now start with another case, and we're going to turn back to Dr. Chodos doing her great expert doctoring job.
Hello, good morning, Miss McGuire. It's wonderful to meet you. I'm Dr. Chodos.
Hi, doctor. Nice to see you.
So sorry your prior doctor retired, but it's wonderful to now get to work with you. So yeah, please just tell me how you're doing today. I noticed you and the prior primary care were working on your medication, your blood pressure, things like that. Were there other things you wanted to discuss today?
Well, so it seems like in my last visits, my blood pressure just, every time it just seems to go up a little bit more. And so that's been an issue. And then my eyes seem to get a little worse, and my hearing gets a little worse. And just lately, I get a little. I see. I have trouble getting some of my words out. Just
Hmm.
sometimes. Just when I get nervous. I'm nervous meeting you for the first time, and my husband doesn't really want me to drive anymore because my vision isn't that good, especially at night. And sometimes I get a little turned around, especially if I'm in, different places or places that I should know where I am. So it's just easier. He does the driving, but that's a little concerning. It makes me a little nervous that I can get confused a little bit, a little lost sometimes.
Hmm. So first of all, thank you. You just gave me so many great bits of information about how you're doing lately and kind of the things going on with you. And that was really, really helpful. In terms of your sight and your hearing, you said they're getting a little bit worse. We'll keep tabs on that because I do want to make sure as your conditions progress, both the hearing loss and the vision loss, that we make sure you're getting up to date correction for those, just to do what we can to make you retain those senses. Thank you for bringing that up. Back to the symptoms with your confusion. Have you noticed that you also sometimes have symptoms where you don't remember conversations or forget things?
You know what? Not big things, but sometimes I'll forget to put the garbage out, which is a weekly thing, and I'll wake up in the morning and I'll realize I forgot to put it out last night. Not big things, little things
Mhm,
like that.
mhm.
Or sometimes I'll forget my best friend's birthday, forget to send a card, or forget to call them. Just like little things like that.
And previously, was that something like you would have forgotten your friend's
Right,
birthday?
right. I would
Got it.
never have forgotten that. Right.
Can you give me a big picture sense of when you think you started noticing these little things creep up, like a year, 2 years?
Oh, I think probably over the past year. I don't think it's been a really long time. Probably over the past year, maybe.
Okay. And then just to be I heard you say your husband doesn't want you to drive. Are you still driving sometimes?
Not really, no, because he's
Okay.
there, so he can chauffeur me around.
And in terms of your medications, can you tell me what your routine is around your medications? Do you think there's any chance you're forgetting to take medications sometimes?
I don't think so. I have the pill box, so we fill them up. He takes some pills too, so we fill them up every week, and I think we're pretty good at that. That's because that's a good routine. So, we take with breakfast and we take them at dinner time. So I think that's pretty good. I don't think we're missing the pills there.
Okay. Um, it sounds like you both have those boxes, which I agree can be really incredibly helpful. Does he like fill your box or double check that you've been taking them, or you're just kind of both in the routine of setting up your boxes together?
Yeah, we
That's
we
how.
set them up. We set them up together.
Okay, and then just one more question about your thinking and your emotions. Basically, would you say that you've noticed any real changes to how you feel emotionally, or even maybe sometimes how you behave, or have you noticed your husband commenting on that?
I don't think so. I think all of that's been pretty good.
Okay. Um, thank you. And I realize I asked a lot of questions in one, so I appreciate it. And let's go through the rest of the visit, and at the end, we'll go over the results and some next steps to really support your brain health.
Okay.
So once again, Dr. Chodos, you are such a good doctor, and that was a really great interview, and it really did you know resonate with me as such a common situation, especially when you're doing like a Medicare annual wellness visit and somebody will sort of raise a concern like this. A lot of people get so freaked out about these senior moments that they have, where they're like, oh my God, is this like the first signs of Alzheimer's disease? And so really you did a great job of guiding that interview to sort of understand how can you start to tease apart what might be really, really worrisome things that we absolutely super concerned about versus things that we might be able to reassure. And that was such a good job.
Thank you. Very kind. It was certainly a lot of fun. Of course, now watching as well, I saw missed opportunities or things I wish I had done a little better to demonstrate to the learners today. But the thing I always try to keep in mind, and maybe people notice me trying to work my way through, is the different aspects of cognition that can change. Everyone's different in that regard, and also trying to understand so different domains of cognition and then how serious their symptoms might be in that area. So she's forgetting things that have been really important to her for a long time, and in a sense biographically integrated. So her best friend's birthday, for example. And then there's the behavioral changes, which I was trying to assess and can be very difficult to ask the person themselves, but people have mood and, you know, um, disinhibition or paranoia or hallucination. So trying to get into that with her was, I think, a little less successful than trying to understand if she's having memory lapses. And then the whole time I'm always trying to think, well, what is the symptom? And is this starting to be in a serious enough range? Like it's not really normal So try not, and is it affecting the day to day, which is sort of the hallmark, really, truly, of dementia, that it's affecting their function. So trying to assess, okay, so you're doing this, you have this strategy to make sure to help you with your medication management, which again, is pretty normal if you have a ton of medications you need to keep track of. But your husband helps you. So trying to tease out, is it that she really needs his help or it's just their routine? And I don't know that that was, 100% clear by the end of the conversation, but it really seemed like it was more the routine than it was, oh, well, a couple of years ago, he had to really start getting involved and making sure I took my meds. So I think, yeah, if you're seeing that as an example visit, it's really about the different types of cognitive domains that people can have symptoms, and then how severe and how relevant to their day-to-day function those changes are. So interesting experience to watch yourself do the interview and try to see where probably could do it better. But it was really also just a great example of someone with some really mild symptoms.
Yeah, the point that really jumped out at me is, when she said that she was sometimes gets disoriented in a place that she should know well, like that is like not normal. And that is the kind of thing that somebody might have some insight into and might be able to share with you. Because this is not getting sort of lost in a new city or something like that. But, she really did say that, there are times when I'm on like the roads that I'm on all the time, when I sometimes I'm not sure sort of which way to turn, and that is really really worrisome. That's not normal aging. That's the kind of symptom that you really want to really latch onto and like, wow, okay, we really got to do a good evaluation here.
Right, perfect. Yeah, like that's a real signal. That's a entering the severe level of of a disturbance or a change in how they're doing, and isn't something you just expect by somebody who happens to be really busy lately or had a lot going on that day. So no real mitigating factors for being totally disoriented in a familiar place. That's such a good catch.
So let's move on to how we're going to do the evaluation. So the next step is really to think about like who should be evaluated for cognitive impairment. And for sure, when somebody is self-reporting something like the case that we just saw, that is really somebody who you really really want to do a cognitive evaluation for. When they're self-reporting something that is really potentially serious, more than I forget somebody's name, but then it comes back to me, but I'm becoming disoriented in a place that I should know well. Or if a spouse or family member or a friend is letting you know that they are having concerns, those are absolutely essential times when you want to do a cognitive evaluation. And you're going to want to sort of ask about symptoms like this at the Medicare annual wellness visit. You want to make sure that you're not dismissing mild memory complaints, which are really, the key situations are the very short-term memory problems, where if somebody's asking the same question 30 minutes later or telling the same story and they aren't even aware that they just told it, those are the situations where you really really need to drill down. And that's essentially, it's so essential in those situations to really get some information from somebody who's spending time with that patient. So like a family member or a close friend, if that's available, because that is really the key insight that you need into how that person is navigating through the world. And so before we move on, take a moment to answer a follow-up poll on educating patients about brain health and screening for cognitive decline. So here's a big busy slide that has all the different options for brief cognitive assessments to detect cognition in the primary care, detect cognitive impairment in the primary care setting. And the one that I really want to highlight here is the mini-cog. The mini-cog is a test that is very, very brief. So it can be done in 2 to 4 minutes, and you can use it as a screening tool. And here, the most important thing to know is that patients who score 3 or less on a mini-cog are really, really at high risk of having cognitive impairment and really do need further testing. And so now let's watch Dr. Chodos giving the patient who we've been following here a mini-cog test.
So we're going to do something, we call it a mini cog. So it's just a quick brain health check. and or one aspect of your brain health that we're going to check. So, if you're ready, I'll get started.
Okay.
Okay. So, please listen carefully. I'm going to say 3 words that I want you to repeat back to me now and try to remember. So, really try to pay attention. And one of the reasons I'm having you repeat them is so that I know you heard me. So, I'll let you know if one of the words doesn't come across. But I'm going to say the 3 words now. The words are banana, sunrise, chair. Please say them for me now.
Okay. Banana, sunrise, chair.
Wonderful. Next, on that paper you have and with the pen, I want you to draw a clock.
Okay.
So a nice big circle, and then please put in all of the numbers where they go.
Okay. Got it.
Okay, you're complete with that part.
Mm-hmm.
Now set the hands to 10 past 11.
Okay.
Okay. What were the 3 words I asked you to remember?
Oh, um, banana, chair. I don't remember the third one.
Okay, that's fabulous. Thank you. Thank you so much for the effort to go through that with me.
And so that was an example of Dr. Chodos doing a great job of giving somebody a mini cog. And you can see how it is a very brief screener, which is really, really handy in the primary care setting. But it's also important to understand that sometimes somebody can do fine on the mini cog and you really still feel like they need more evaluation. Or if they don't do fine on the mini cog, then that's really not enough to make a diagnosis. You really want to sort of have a fuller cognitive evaluation. And it's going to be really often difficult to do that right at the moment that you are identifying this as a possible problem. And so this is really, like, I think one of the biggest sort of great sort of teaching pearls is that rather than trying to squeeze a cognitive evaluation into even a Medicare annual wellness visit or an office visit where you're also talking about somebody's diabetes and their knee, you really want to schedule a dedicated visit to just do a cognitive evaluation. And again, so strongly encourage a family member or close friend to come with them to that visit, because you really are going to want to get their input to understand how the patient is navigating through the world. And you can really bill those as a pretty high reimbursement visit, that even if it is in your normal visit length, now that you can bill by time that includes not just face-to-face time, but time prepping for the visit and charting afterwards, these are really 40-minute visits in total on that visit. That's a level 5 visit, which is double the RVUs for a level 3 visit, and really makes it a little bit easier to understand how to make this practically work in a primary care setting. And so what are the 3 parts of that dedicated visit to do a cognitive evaluation? So first, we recommend using a cognition checklist that we're going to show you in a second that has reversible causes, factors you can fix. You really are going to want to do a more in-depth evaluation of cognition, really beyond just the mini cog. You're going to want to do a test like the Montreal Cognitive Assessment or MOCA test. And again, hopefully you're going to be able to get a family member or close friend to come to that visit with them, to get input from them, to sort of be able to get that collateral information that you can use to put together with the cognitive test to really make a diagnosis. And so here's what a cognition checklist should look like. And I recommend making this a smart phrase in your electronic health record. You really you're going to want to have this checklist available for you. The labs are relatively easy to remember. These are the things that generally we learned in school and aren't hard to remember: to check a vitamin B12 level, to check someone's TSH to make sure that they don't have hypothyroidism. You want to remind yourself to look at their medication list. You're especially wanting to focus on sedating medications or anticholinergic medications. And here you especially want to remember medicines that might not even be on their medication list, because they are using them over the counter. And so the most common situation in that scenario is somebody who is using a sleeping aid. So somebody who's taking a medicine like Tylenol PM that has diphenhydramine in it, which is a very strong anticholinergic medicine that can really start to impair people's cognition, especially as they get into their 70s, 80s. The other really common medicine is that sometimes people are sort of put on and left on, even though they may not be doing that much getting that much benefit from them, is a medicine like oxybutynin for urinary incontinence, also a very strong anticholinergic medicine. The other really important thing that you don't want to forget to ask is how much alcohol are you drinking? Because even mild to moderate drinking, as people are in their 70s and 80s, and especially if they're starting to develop concerns about their cognition, that mild to moderate drinking really can start to impair their cognition, and really, so don't forget to ask about it. And if they're drinking more than even one drink a night, that is a situation where reducing that alcohol intake really can make a big difference in their thinking. And then you want to think about what are the comorbidities, the conditions that by treating them, you actually can improve people's cognition. And so things like untreated or undertreated sleep apnea, undertreated or untreated hearing loss, depression, these are the modifiable things that we really can do to oftentimes reverse the cognitive impairment that people might be experiencing. And so here's that big busy slide again, but this time we're going to focus on a more in-depth test that you can use to evaluate somebody's cognition, which is the Montreal Cognitive Assessment, which is the MoCA test that really is the best validated test for really identifying cognitive impairment in the primary care setting. This is a test that has better sensitivity and specificity than the mini mental status exam. The mini mental status exam has some weird copyright infringement aspects to it, so would not recommend using the mini mental status exam. Really recommend using the MoCA test as the much more effective test for evaluating cognition in the primary care setting. And so that's what you're going to do at this cognitive assessment visit. You're going to put together the results of a MoCA test together with family input, and that is really a super robust evaluation of somebody's cognitive function that you can do in the primary care setting. And when you're talking to the family member or the close friend, one of the most important things that you're going to want to get from them is the kinds of things that Dr. Chodos was doing such a good job of asking the patient themselves, but now you're going to get such a more detailed and rich collateral experience by talking to the family member or the close friend who's really able to say, like, are they ever repeating the same question to you 30 minutes later? Because that kind of short-term memory loss is extremely worrisome. Those are not the senior moment sort of normal aging problems. If somebody is asking the same question 30 minutes later, it's not even that they don't remember the answer to the question, and so they're asking again, but they don't even remember that they asked it, that is really worrisome. Losing the ability to do a complex task that they once found to be easy, such as cooking a complex recipe or putting up sort of complex holiday lights. If that used to be easy for them, but now they're getting stuck on how to sequence that task, that is very, very, very worrisome. And like we saw in the video earlier, if somebody is getting disoriented in a familiar place, like they're suddenly not sure which way to turn, that is a very, very high risk, worrisome collateral information that you want to try to get from a family member or a close friend. And you're going to put that together with the results from the MoCA test. And again, this is such a valuable test that it does take longer than the mini cog, but it's got a much, much better sensitivity and specificity, especially for mild cognitive impairment. The MoCA test is really an important tool to get used to using in the primary care setting. And in terms of how to get input from that family member, one of the ways that you can use a structured tool to get that interview from the patient's family or close friend is a questionnaire called the 88. This is a validated list of 8 questions that you can ask the family member or close friend. It's really important to say that rather than, unlike the MoCA, which is like a scored instrument, even though this can be used as a scored screening tool, I really recommend using it more as a structured way to to lead you through the interview with the family member or close friend. And so that if somebody says that somebody's having less interest in hobbies or activities, rather than just giving a point and moving on, that's really an opportunity for you to ask more of the family member or close friend. Could you tell me more about that, and understand that you really can get important functional information from the family member that really is incredibly important collateral information. And it's a really good idea to really get used to using other screening tools that you might want to have at your fingertips. So the PHQ-9 is one that we use all the time in primary care. It's a very, very important one to use, especially in the mild cognitive impairment setting, where you really can identify depression as a really a major component of what their cognitive impairment might be. Also really good to have a functional screening tool, which is actually built into the Medicare annual wellness visit questionnaire. Those activities of daily living questions in the annual wellness visit questionnaire are really, really important to help you get a sense of how is this person sort of functioning day to day in their lives. And so again, we're going to put the result of the MoCA test together with the input from the family member or close friend. And now let's say that their MoCA test is abnormal, intermediately low, say in the 18 to 25 range out of 30, and their family member is saying that, yes, they have been asking me the same question 30 minutes later, but they are still fully independent in their activities of daily living. They're still dressing and cooking and cleaning the house fine. So that is a diagnosis of mild cognitive impairment, which is such an important diagnosis to make in the primary care setting, because all of a sudden, by putting that diagnosis on somebody's chart, and it's reminding yourself, reminding your colleagues, reminding other people that they may be encountering in your health system, that this is somebody who is really going to need some extra special care to make sure that they are understanding what's going on. But let's say that their MoCA test is much lower than that. Let's say a MoCA test result is 18 or lower, and again the observer is reporting that they are saying they are doing things like asking the same question 30 minutes later, and there are definitely changes in their activities of daily living. So if they're not able to cook for themselves anymore, that is a diagnosis of dementia. And that is really, again, a diagnosis that we can and should be making in the primary care setting. And so before we move on, I want to give you a second now to answer another follow-up poll about cognitive testing. All right, and so now we are really at that diagnostic step. We have done the MoCA test, we have gotten the interview from the family member or the close friend, and we really are ready to make a diagnosis of potentially mild cognitive impairment or a diagnosis of dementia. And again, remember that the difference between mild cognitive impairment and dementia is whether they are independent or with their activities of daily living, or have lost the ability to do some activities of daily living. And this is a slide that just shows you how that spectrum that goes from normal aging to mild cognitive impairment to dementia really lies on top of what all of the potential neurocognitive degenerative etiologies of that could be. And so Alzheimer's disease is by far the most common cause of cognitive impairment. But as you can see, there are many other causes that often can be overlapping that can be the etiology for that cognitive impairment. And so now I just want to get down a little bit deeper into sort of what is this thing, mild cognitive impairment. I can tell you when I was in medical school 20 years ago, that this really didn't exist as a diagnosis. And it is really so important for practicing primary care providers to know about this very, very clearly defined syndrome, which is mild cognitive impairment, where the MoCA score, like I said, is definitely abnormal, but it's not. It's often in an 18 to 25 range, but somebody's still fully independent with their activities of daily living. That's a diagnosis of mild cognitive impairment, and this is a diagnosis in and of itself. It's really important to understand that this is not simply early dementia, because some people with mild cognitive impairment do not progress to dementia, and yet a very large majority do. And so it's so important to identify that most people with mild cognitive impairment do in fact have early Alzheimer's disease, but not all. And this is just such an important moment for primary care to really sort of embrace, engage, and really think about all the things that we can be doing to maintain somebody's brain health when they have mild cognitive impairment. And so I want to come back to, again, just like how important this diagnosis is to make, because when we make a diagnosis of mild cognitive impairment or dementia, by putting it on their problem list, by actually using one of those ICD-10 codes, it can be a little bit scary because it's like, wow, this is kind of a big deal. And am I sure that I really sort of want to do that? And I really want to make the case of how much value there is to doing it. Really, it helps communication to other clinicians and staff in your clinic. It's the first step to really engaging patients and families in sort of how, we do really need to face this major thing that is going on with one of the most important organs in your brain. And what can we do? How can we make a plan to really improve your brain health? And it really, without making this diagnosis, we really sort of still are kind of have a closed door. But by making that diagnosis, we open the door to getting patients better care. So it's important to take a moment to think about, what happens when you do this evaluation and you end up with kind of like in between results. This is uncertainty that we are so used to dealing with in primary care. So somebody may have kind of borderline diabetes, somebody may have borderline osteoarthritis, and it's a little bit hard to know what to do. And so you really want to have like a set of sort of options for you, where on one hand, you might just want to repeat the evaluation in 6 to 12 months. That's a situation where if you might have access to a neuropsychologist, getting even more in-depth cognitive assessment is a perfectly reasonable thing to try to get. This also might be a situation where the patient and or you really might want to just refer somebody to a specialist, a neurologist or a geriatrician, to really help to tease out what do these intermediate results mean. It's just so important to make that sort of observation that there is this potential for cognitive impairment and really have a plan to do one of these three things next to make sure that this isn't sort of swept under the rug. And so again, just like going back to that brain health checklist, I mean, so you're getting sick of us saying this over and over again, but these are the things that we really do need to embrace in primary care to make a difference in people's lives, reducing people's alcohol intake, taking a close look at their medication list, and especially worrying about over-the-counter medicines, contributing conditions like sleep apnea, hearing loss, and vision loss that really can improve people's brain functioning, recommend exercise, just like Dr. Chodos was talking about at the beginning, cognitive stimulation, which really should be centered around encouraging social engagement. And this is another moment where I want to remind you that there are practice tools that are available where you can print out some of these tips that you can use with your patients. All right, so now let's, what do you do next? So after you have done that cognitive evaluations, you really want to make sure that you are setting the next step. So if the evaluation looks okay, then you've done a huge benefit for the patient by reassuring them and reassuring yourself, and you can really discuss ways to keep their brain healthy. And you could maybe consider repeating the evaluation in 12 months, especially if there were maybe still some features that were a little bit concerning. You maybe have found some contributing factors that you can start working on to improve people's brain health. If it looks like mild cognitive impairment or dementia, you really want to have a phrase ready to pivot yourself, because you're probably not going to have adequate time to do the full evaluation of setting a plan. And so you're going to be ready to say something like, this is a lot to take in and work through. Let's schedule another appointment soon to review what this means and make a plan. Encourage the family member to come to that visit also. So important to really sort of set that next step to make a plan. You do not want to sort of diagnose an adios. That's like one of the worst things that can happen from cognitive impairment. You really want to be ready to have the patient back so you can set a plan to talk about what the next steps are. And so let's talk just a moment of what you might do at that next visit in terms of after you have made a new diagnosis. You want to ask permission. Is it okay if I share with you what's going on? Acknowledge fear, also share some hope and some optimism. Make it clear that you're going to provide ongoing support and that this is a first of a series of ongoing visits. And again, there's tips and best practices that you can download to remind yourself of how to talk about this new diagnosis. And so before we move on, let's take a moment to answer a follow-up poll about disclosing in mild cognitive impairment or dementia diagnosis to patients and their care partners. And so not a bad idea to have a checklist for yourself on how to talk, how to run that visit where you are setting a plan for a newly diagnosed patient. You're going to counsel them about the diagnosis, consider offering referral to a specialist, mention that there are newer anti-amyloid drugs that can slow the progression of Alzheimer's disease. You want to suggest community resources and just go back to that checklist of recommended brain interventions. All right, so here are the take-home messages. Don't forget that brain health in so many ways really is heart health. Don't forget to address those 14 modifiable risk factors and things that we can do to prevent dementia from happening. Don't be ready to do to perform a cognitive evaluation on all patients with a suspected cognitive decline, and so important to try to get a family member or close friend to be at that visit to get that input for you. And when patients have suspected neurodegenerative disease such as Alzheimer's disease, really important to offer the option for a comprehensive diagnostic workup. You really are going to want to employ shared decision making in those situations to engage patients and care partners in informed discussions about their assessment, the diagnosis, and their expected clinical course. All right, so don't forget to go to the website, peerreview.com, brainhealth25, complete and submit your post-test and evaluation for credit, download the slides and the practice aids that we've been talking about, and you can watch the replay of this event in the next 24 hours and the online activity in the coming weeks. Thanks so much for joining us.
Thanks, everyone.